Vanessa just did a fabulous job of giving the carer's perspective, and I'm here today to give more of the clinical scientific side, so a bit more boring, but hopefully we'll cover any questions that come up too at the end. I am a dermatologist, so I work in private practice and at a public hospital in Brisbane, and I see a lot of patients with eczema, both children who are affected and, as Vanessa mentioned, increasingly more and more adults. I thought I'd start off today just talking about what eczema actually is and what we as dermatologists see it looking like in the skin. I'll briefly touch on the causes of eczema and then look more at some clinical photos of recognising different types of eczema and how it can look in different skin types and different age groups. Briefly touch on management before passing over to Laura. So eczema, I always think it's very appropriate that eczema is derived from actually a Greek word meaning to boil over, because this is literally in the skin what it looks like. It looks like little erupting volcanoes or red, itchy, inflamed patches that when it's untreated and it's left to develop on its own, it really does get angry, quite raised, just like a little volcano would in the skin. And as you can imagine, this can get more and more irritating for the patients that suffer with these. So it does tend to usually occur in people who have what we refer to as an atopic background, and that links conditions that are quite genetically linked as well as having a pathophysiological link. And there's three main atopic conditions: atopic dermatitis, or which is really the medical term for eczema, with asthma, and allergic rhinitis or hay fever. So often when I'm talking to a patient that's newly diagnosed with eczema, I'll ask if they have any of these quite commonly coexisting diseases, or if there's a family history of any of these, because that's quite helpful to recognise that there is a genetic link to these conditions. And eczema can look very, very variable in the skin. So it can be anything from just dry patches of skin, which haven't developed that very red, angry volcano side yet, more of this red, angry, irritated look. So there's quite different morphologies that we come across, and that can change depending on the person's lifestyle, their activities, their skin type. There's many different contributors to determine what a person's eczema looks like, but it's very much that it's not the same in every person. This is the look of generally a very secondarily infected eczema. So you can see that it's quite thick, the skin's quite swollen with the inflammatory process, and there's quite a lot of crusting. So this is often very sore, painful, and can take a bit more of a treatment regime to fix than the previous types of eczema. This is more of a chronic eczema look. So this takes on an appearance of what we call lichenified skin, when the skin actually thickens in response to that chronic inflammatory drive that's existing. And this as well can take a different treatment approach and quite a longer treatment plan to clear in these cases. So what causes eczema? And this is a question that I do commonly get asked, particularly when patients come in and they're children and they're with their parents who sometimes have never had any exposure to eczema before. And I find it can be quite confronting to be given this diagnosis of what is often a very long-term, even lifelong condition, and quite a chronic condition. So a condition that we never really cure, and we instead aim to control. And I think it's really important for parents, particularly when they're confronted with this diagnosis, to understand that it's nothing that they're doing to their children's skin, it's nothing they're putting on, it's nothing they're feeding their children. In most cases, eczema is dominantly caused by genetic makeup. So there's nothing that we are doing to our children to give them this condition. And I find that that's often a very relieving thing for parents to know, because many of my patients do come in concerned that they are presenting with this because of something that they've done in their own life, or something that they're inadvertently putting on their child's skin, and that is most definitely not the case. Eczema is one of those diseases that's a very complex interplay between the underlying genetics of the individual and also the environment in which they live. So often it needs to be in, as I commonly say, the wrong place at the wrong time to come about. And as Vanessa alluded to, many people go years without knowing they have eczema, and then in their 20s, 30s, 40s, move to a different climate and all of a sudden have quite generalized, quite severe eczema. And that's not an uncommon phenomenon, and that really demonstrates how that interplay of genetics and environment, wrong place, wrong time, is necessary often to see the phenotype of this disease. I often explain to my patients, and I've actually got a diagram here on my desk when we talk about the underlying cause, I ask them to imagine the skin as a brick wall. And there's this thing called filaggrin protein, which is on the first chromosome in each of us and codes for the mortar between the bricks in our skin brick wall. So the filaggrin is key to keeping that brick wall very even and making sure the bricks are evenly stacked together to form a nice firm barrier on the outside of our skin. What happens with eczema and this filaggrin protein on the first chromosome being a little bit miscoded, for want of a better word, is that the mortar isn't forming properly. So the bricks aren't stacking or gluing together nicely, and that leads to quite a dilapidated, falling apart brick wall. And if you can then imagine that as the skin surface, that isn't forming a nice, clean, even barrier to the outside insults that we would like. And that then develops into this cascade of inflammation and falling apart of the skin that we know as eczema. There's many different environmental triggers that can set eczema off, but this is a list that I commonly see in my practice and that we often pick up patterns of causing skin irritation or breakdown. So winter weather is a very common trigger, and often change of season even, not just cold weather, but that change from hot to cold. Frequent washing and hot water is quite stripping to that skin barrier. Soap, antiseptics, low humidity or change in humidity, high temperatures, chlorine, sand and salt. So they're often the common triggers that will disturb that brick wall barrier and set off the cascade or the vicious cycle that can stir up eczema. Eczema does tend to have different patterns that it likes to affect in different age groups, and that's a lot of that is because of the different styles of walking and mobility that's characteristic of each age group. So in an infant or a less than 6-month-old child, they're quite immobile, but they are very focused on their face. There's a lot of saliva, there's a lot of insult to the facial skin. So you'll often see eczema affecting the cheeks and the forehead. That changes as the child becomes mobile, and they're often on their hands and knees, and then we often will see a lot of eczema on the acral surfaces on the knees that are being exposed to rough surfaces or sand or salt or being in and out of a pool. As the child walks, then we tend to see again the eczema affecting the lower limbs and the hands and forearms as they're exploring. These areas are commonly impacted. As they get older again, as an adult, it tends to morph more to the dorsal forearms and also truncal skin in an older age group. So it definitely follows a different pattern with the age group of growing up and the different skin surfaces that are more exposed to the elements. Just to give you a quick reminder of what it can look like in different age groups, these photos show that less than 6-month-old eczema, so very dominantly affecting the cheeks and the chin, areas that are in frequent contact with hands and saliva and food, irritating food substances. The preschooler often develops eczema on the lower legs, upper thighs, and it's really common for us to see eczema in these age groups that are secondarily infected due to impacts of bacteria or particles that are causing quite a degree of secondary organism infestation, if you like, in skin that is barrier impaired. Next slide. The school age kid very commonly describes flexural eczema. So these are areas of the skin often that are occluded, so behind the knees or in the elbow joints, where they can be sweat or material that's irritating the skin frictionally, and that can disturb that skin barrier, and that's where they then start scratching and that eczema cycle starts. And so this is to compare to adult eczema, which is generally truncal skin, upper back, often hands are another site, and particularly in young mums that are changing nappies, washing hands frequently, exposed to baby wipes and other irritants can really kick off the eczema. And lower limbs, again, is a common site for adults. So the management of eczema really has 3 underlying principles. Firstly, to identify the common skin irritants that the patient is being exposed to. And I think Vanessa highlighted a really important point that as a carer, your job is vital to helping the treating dermatologist or general practitioner by highlighting elements of the patient's life that may be causative in their eczema. Because oftentimes, Vanessa mentioned, we're with the patient for such a short period of time, it's really hard from that snapshot to identify what their lifestyle's like, what irritants they might be commonly exposed to, what their day-to-day life looks like. So as a carer, we would very much appreciate your help in trying to get the full picture of how we can best tailor a plan that best addresses the skin and gives us the best chance of restoring that skin barrier. That's really the second aim, is to improve that overall barrier function. We have to treat the eczema, sure, but we also have to rebuild that brick wall, so to give it the best chance of maintaining the skin barrier and keeping the skin healthy. And thirdly, is to treat areas of inflammation and active eczema, and that might be through topical measures, sometimes through intralesional measures, and sometimes even through oral or biological therapy. So there's lots of different treatment approaches to maintaining the skin eczema free. And this is a little plan we developed just to really highlight the 3 zones that eczema skin can commonly be grouped into. So often when I'm managing a patient for the first time, they'll come to me in this red or yellow zone, and I'll say, look, we're trying to get you into the green zone. We're never going to be able to be cream free because we do need to keep moisturizers and barriers into your skin at all times to prevent relapse. But at the moment, we are on an intense regime, and often these red and yellow regimes can be quite arduous, quite intensive for both the carers and the patient. But I think working towards getting into a green zone or a more maintenance, less intense skin plan is often an incentive for everyone. So this is what I generally will send a patient home with the aim of getting into that healthy green zone of maintenance therapy.